Hyperreligiosity refers to an intense preoccupation with religious or spiritual ideas, practices, or experiences that exceeds culturally accepted norms. While strong religious commitment is a normative part of life for many individuals, hyperreligiosity becomes clinically significant when it interferes with functioning, reflects underlying pathology, or is out of context with the person's previous behavior. This phenomenon can occur in various psychiatric and neurological disorders, and understanding its roots and manifestations is crucial for accurate diagnosis and compassionate care. Hyperreligiosity is not a diagnosis in itself, but a symptom or behavioral pattern. It involves excessive religious speech or writing, frequent or compulsive prayer or rituals, belief in personal communication with God or spiritual entities. Preoccupation with moral purity, sin, or divine punishment, drastic life changes based on perceived spiritual revelations. What distinguishes hyperreligiosity from devout faith is intensity, inflexibility, and dysfunction. It often emerges suddenly, is resistant to reasoning, and may coincide with delusional or obsessive thinking. Psychiatric conditions associated with hyperreligiosity, bipolar disorder, mania. During manic episodes, individuals may experience spiritual grandiosity, believing they are prophets, chosen by God, or on a divine mission. Hyperverbal religious preaching or rapid spiritual speech may occur. Risk-taking behaviors may be rationalized as part of their spiritual purpose. Schizophrenia and schizoaffective disorder, religious delusions, such as belief in being the Messiah or in direct communication with angels or God, are common. Hallucinations may include hearing the voice of God. These experiences are often fixed, unshakable, and disconnected from traditional religious frameworks. Obsessive-compulsive disorder, OCD. In a subtype known as scrupulosity, individuals obsess over religious correctness, morality, and fear of divine punishment. Compulsions include repetitive praying, confessing, or avoidance of perceived sinful thoughts. Unlike psychosis, individuals with OCD typically recognize their thoughts as irrational but feel compelled to act on them. Post-traumatic stress disorder, PTSD. Following trauma, some individuals develop intense religious fixation as a coping mechanism or perceived form of atonement. They may see their suffering as punishment or divine testing. Autism spectrum disorder, ASD. Some individuals may adhere rigidly to religious rules or interpret spiritual texts literally. Their engagement with religion may be rule-based rather than emotionally or spiritually driven. Neurological conditions linked to hyperreligiosity, temporal lobe epilepsy, TLE, is perhaps the most well-documented neurological source of hyperreligiosity. Individuals may report religious visions, overwhelming spiritual experiences, or a sense of divine presence during seizures or auras. Between episodes, they may become increasingly religious in speech, dress, and habits. This has been referred to as part of the Gastaut-Geschwind syndrome, which includes hyperreligiosity, hypergraphia, and altered sexuality. Frontal lobe disorders. Damage or degeneration in the frontal lobes can lead to disinhibition and poor judgment, including extreme religious preoccupations. Some individuals lose the ability to distinguish metaphorical from literal spiritual interpretations. Neurodegenerative diseases. Conditions such as frontotemporal dementia may lead to personality changes, including rigid or obsessive spiritual behavior. Hyperreligiosity in these cases may mark early personality shifts. Brain injury, traumatic brain injury, TBI, especially affecting temporal or frontal regions, may result in new or intensified spiritual interests. Cultural and contextual considerations. It is essential to distinguish culturally sanctioned religious fervor from pathological hyperreligiosity. Cultural background, religious tradition, and personal history all play roles in what is considered normal religious expression. For example, a monk praying for 8 hours a day in a monastery is within normal context. A person who previously had no religious interest suddenly preaching on the street as a divine messenger may be displaying pathological hyperreligiosity. Clinicians must assess whether the behavior is new or long-standing, if it interferes with daily life or relationships, if it includes delusions, hallucinations, or compulsions, whether the person is distressed or impaired by it. Treatment approaches. Treatment of hyperreligiosity depends on its root cause. A careful differential diagnosis is essential. Interventions may include pharmacological treatment, antipsychotics for schizophrenia or bipolar disorder, mood stabilizers for bipolar mania, SSRIs for OCD scrupulosity, anticonvulsants for epilepsy-related symptoms. Psychotherapy, cognitive behavioral therapy, CBT, for scrupulosity and obsessive thoughts. Supportive therapy to explore spiritual experiences without judgment. Trauma-informed care when hyperreligiosity follows trauma. Neurological management, seizure control in epilepsy using medications or surgical interventions. Monitoring progression of neurodegenerative disease. Collaboration with religious leaders, involving culturally competent spiritual advisors, can help bridge understanding and reduce stigma. Faith leaders may assist in distinguishing religious commitment from mental illness. Ethical and clinical challenges. Treating hyperreligiosity requires clinicians to walk a delicate line, avoid pathologizing genuine faith, respect the client's spiritual identity, recognize when belief becomes delusion or obsession, engage in non-judgmental dialogue to preserve trust. Misdiagnosing religious passion as pathology, or vice versa, can harm both diagnosis and therapeutic alliance. Training in religious diversity, cultural sensitivity, and psychospiritual integration is essential for mental health providers. Historical and cross-cultural perspectives. Hyperreligiosity is not a new phenomenon. Historical records describe individuals with extreme religious behaviors across many traditions. Christian mystics reporting visions, fasting, and ecstatic prayer, Sufi dervishes practicing intense spiritual rituals, ascetics in Hindu and Buddhist traditions engaging in extreme discipline. Some of these figures were revered as saints or spiritual masters, while others were viewed as mad or possessed, depending on the cultural lens. This dual possibility reflects how society defines normality, holiness, and pathology. In modern global psychiatry, awareness of these cultural dimensions is crucial. In one culture, a person may be seen as spiritually gifted. In another, they may be hospitalized. Thus, context, community meaning, and the presence or absence of distress and dysfunction are key in clinical decisions. Research and neuroscience findings. Emerging research explores how religious experience is processed in the brain. Functional MRI studies have shown activation in the temporal and frontal lobes during prayer or meditation, overlap between religious experience and emotional regulation circuits, altered dopamine signaling in states of spiritual ecstasy or delusion. Studies in temporal lobe epilepsy reveal that certain religious experiences may be linked to seizure activity or abnormal brain connectivity. While this does not invalidate spiritual experiences, it emphasizes the neurological underpinnings of perception and belief. Other research investigates the relationship between trauma, dissociation, and hyperreligiosity. People with early life trauma may gravitate toward rigid belief systems or spiritual frameworks as a means of finding safety, meaning, and control. In such cases, hyperreligiosity may serve as both a symptom and a coping strategy. Case examples. A 32-year-old man with bipolar 1 disorder enters a manic episode and begins preaching loudly in public parks, claiming he is the reincarnation of an Old Testament prophet. He stops eating, isolates from family, and refuses sleep, believing he is receiving divine instructions. Hospitalization and mood stabilization lead to gradual return to baseline. A 28-year-old woman with OCD develops scrupulosity, spending 6 hours a day praying and confessing. She avoids touching objects she deems unclean and is tormented by thoughts of eternal damnation. She is treated successfully with SSRIs and CBT. A 47-year-old man with temporal lobe epilepsy begins having intense visions of angels during seizures. He becomes preoccupied with religious writing and develops a new sense of spiritual purpose. His symptoms improve with anticonvulsant therapy, though his personality remains spiritually oriented. Integration with spiritual care. Clinicians who work with hyper-religious clients may benefit from collaboration with chaplains, spiritual directors, or religious counselors. These professionals can help discern between religious devotion and pathology, provide culturally appropriate support, create non-judgmental space for exploring spiritual identity. Mental health care should not demand spiritual neutrality, but rather embrace an inclusive approach that sees religious life as part of the human experience. The goal is not to eliminate spiritual expression, but to ensure it is integrated, healthy, and supportive of well-being. Conclusion: hyper-religiosity exists at the intersection of belief, brain function, and behavior. It can arise from multiple etiologies, including psychiatric disorders, neurological conditions, and trauma responses. Distinguishing it from culturally appropriate spiritual devotion requires sensitivity, training, and a nuanced understanding of both clinical and religious contexts. With careful assessment and multidisciplinary care, individuals affected by hyperreligiosity can find healing, regain function, and preserve the core of their spiritual identity.